Hey guys, welcome back to EMT training. It's Gabby Reed again, and today we're going to be talking about respiratory emergencies. A respiratory emergency occurs when an outside factor alters the patient's ability to breathe. This could be caused by a variety of things, such as medical conditions, injuries, and behavioral health emergencies. In this training, we're going to talk about 6 different causes of respiratory emergencies, such as airway obstructions, chest trauma, inhalation injuries, anaphylaxis, behavioral health emergencies, and dyspnea. We will also be discussing oxygen administration and usage of other BLS medications. Listening to patients' lung sounds is an important part of patient assessment. This is also called auscultation. The sounds that you hear should be noted on the PCR to better help the doctors and nurses at the hospital take care of the patient. Watch the bottom right of the screen, and I'll show you where to place the stethoscope when listening to patients' lungs. On the front side of the patient, you should place the stethoscope just under the collarbone on both the left and right sides. On the lateral sides of the patient, place the stethoscope again on both the left and right. And finally, on the back side of the patient, place the stethoscope just above the shoulder blades on the left and right. With each placement of the stethoscope, you should encourage your patient to take a deep breath in and out. And these are the sounds that you should hear. Now we'll go from top to bottom of this list and listen to each of these lung sounds, and I'll tell you a little bit about each one. Bronchi occur when there are secretions or obstructions in the larger airways. It's often associated with COPD, pneumonia, or bronchitis, and it sounds like a continuous gurgling sound. Wheezing is a result of inflammation and narrowing of the airway in any location, from your throat into your lungs. It's often associated with difficulty breathing and asthma, and it sounds like a continuous whistling sound. Crackles occur to excessive fluid in the airways. It's often associated with lung infections like pneumonia or other conditions like congestive heart failure. The sounds are very discontinuous. Stridor is more commonly heard in children, and it usually indicates an obstruction or narrowing of the airway. In this recording, you'll hear a baby experiencing stridor. When administering oxygen, there are 2 things that you should consider. Number 1, is your patient conscious? And number 2, can your patient maintain their own airway? There are 3 main methods of administering oxygen for BLS providers: the nasal cannula, the non-breather mask, or NRB, and the bag valve mask, or BVM. The CPAP is only used by ALS providers. The nasal cannula is used to administer the least amount of oxygen at 2 to 6 liters per minute. It may only be used on conscious patients who can maintain their own airway. The non-rebreather mask, or NRB, can also only be used on conscious patients who can maintain their own airway. When using the NRB, set the oxygen flow rate to 10 to 15 liters per minute. The bag valve mask is used for an unconscious patient who is not breathing. The person squeezing the bag is acting as the patient's lungs exchanging oxygen. Set the flow rate to 15 to 25 liters per minute. The CPAP, again, is only used by ALS. This device helps to keep the airway open and promotes exchange of carbon dioxide for oxygen in the lungs. ALS providers should only use this on patients who are alert and have a pulse oximetry of less than 90%. The ALS provider will set the oxygen flow rate to 20 to 25 liters per minute. Airway obstructions are often caused by a foreign object trapped in the airway. When treating these patients, consider their mental status. If the patient is conscious, then encourage them to cough, which may help to free the object. If the object becomes unlodged, monitor your patient afterwards and make sure that they can breathe on their own. If the object does not free itself or the patient is having difficulty breathing, then administer oxygen with the NRB. Transport the patient in a sitting position so that the object does not further lodge itself in the throat. Keep a watchful eye on your patient to ensure that the airway does not become completely obstructed. If you find the patient unconscious or if your patient slips into unconsciousness, then open their airway by performing the head tilt chin lift or the jaw thrust maneuver. Once the airway is open, look inside the mouth and remove any obstructions you may see. If the patient is still unconscious, then begin CPR. Chest trauma can cause difficulty breathing. One such injury is flail chest, which is due to blunt force trauma that breaks the ribs. The patient's chest will fall on inspiration and rise on expiration, which is the opposite of normal. For a patient with flail chest, consider their mental status. If they're conscious, then administer oxygen with the NRB. If the patient is unconscious, then administer oxygen with the BVM. Here's a diagram of flail chest. A sucking chest wound is due to penetrative trauma that creates a hole in the chest cavity for air to travel into and out of. For a patient with a sucking chest wound, cover it with an occlusive dressing. Do not try to remove any objects that may be stuck in the wound. Once the wound is covered, administer oxygen with the NRB if they are conscious or BVM if they are unconscious. If dyspnea increases, remove the dressing momentarily only during exhalation. Here's a diagram of a sucking chest wound. When responding to a suspected carbon monoxide exposure, it is extremely important to consider scene safety. Inhalation of carbon monoxide can kill you. You cannot see, hear, or smell the carbon monoxide. The only way to detect it is with a special sensor. If you encounter a suspected carbon monoxide exposure, call ALS before entering the space. Have them check the area before you enter the scene. When you locate the patient, move them to fresh air as soon as possible. Consider taking the backboard or scoop with you when you enter the space in case that the patient is unconscious. Begin oxygen administration immediately with the NRB for a conscious patient or BVM for an unconscious patient. If ALS is present, then have them administer oxygen with the CPAP. Airway burns can cause the throat to swell, leading to difficulty breathing. A patient with an airway burn due to chemical inhalation may have burn marks around their mouth. Look for paraphernalia at the scene that may indicate that your patient has inhaled chemicals. If you suspect chemical inhalation, call poison control for further medical assistance. They will be able to provide you with specific guidance on treating the patient. A patient who has inhaled smoke may also experience airway burns. If you are called to the scene of a fire and your patient is having difficulty breathing, then you may suspect that they have airway burns. Elevated CO levels are another good indicator of smoke inhalation. For patients in both of these cases, the treatment is the same. Move the patient to fresh air and administer oxygen via NRB for a conscious patient or BVM for an unconscious patient. If ALS is present, then administer oxygen with the CPAP. Anaphylaxis is a rapidly progressing, life-threatening allergic reaction that can be onset by either known or unknown allergens. Key signs that your patient is anaphylactic are a swollen face and mouth, difficulty breathing, and a low blood pressure. If your patient is anaphylactic, you should immediately call ALS. Treat anaphylaxis by administering epinephrine with either the EpiPen or the check and inject. If your patient is wheezing, you may also administer albuterol via the nebulizer. When administering epinephrine with the EpiPen, it is important to remember that the EpiPen can go through clothes. There are instructions on the EpiPen on how to use it, and I've typed them over here to the left, so you can pause the video here if you want to read it. The regular EpiPen administers an adult dosage, or 0.3 milliliters, to the patient. Do not use the regular EpiPen on a child. There is a special EpiPen called EpiPen Junior made just for children. It administers a child's dosage, or 0.15 milliliters. If you do not have an EpiPen Junior, then use the check and inject method. You may repeat the dosage of epinephrine up to 1 time if the patient's condition does not improve after 5 minutes. Do not reuse the same EpiPen. If you do not have a second EpiPen, then use the check and inject. This slide discusses how to use a check and inject properly. Pause the video here if you want to read all of the instructions, but I'll just cover the highlights. The first important thing to remember is that the syringe cannot go through clothes, so you have to cut or remove a section near the upper outer thigh. Then locate the check and inject kit in your EMT bag. It should be found in the blue BLS medications bag. Make sure that it has not expired. Then verify the dosage. For an adult, you'll inject 0.3 milliliters of epinephrine, and for a child, you will inject 0.15 milliliters. Most all of the patients on campus will be adults. Locate the 0.3 mark on your syringe and hold the medication bottle upside down and insert the needle into the rubber top. Pull the plunger back to the 0.3 milliliter mark and tap the body of the syringe to remove any air. Once the syringe is loaded, inject the medication into the thigh at a 90-degree angle. Then massage the injection site for 30 seconds and cover it with a Band-Aid. Finally, make sure that you document the injection. Continue to monitor your patient, and if the condition does not improve after 5 minutes, then you can re-inject them. The link on this slide will direct you to a helpful video that shows you how to set up and administer the check and inject. Dyspnea is defined as difficult labored breathing. This can be brought on by physical or medical conditions. Dyspnea on exertion occurs because of excessive physical activity. The body may feel that it is not getting enough oxygen, so the brain sends signals to the respiratory system to breathe deeper and more quickly. This leaves the patient feeling like they can't catch their breath. We mostly see this during activities such as NDOC, the PRT, or recognition. For these patients, administer oxygen with the NRB and have them sit in the tripod position. This consists of the patient leaning forward and resting their hands on their knees, which will open up their airway. You can see a demonstration of it in this picture. Wheezing as a result of asthma or anaphylaxis may also cause difficulty breathing. In these patients, the airways narrow and the lungs tighten as a response to irritants that are introduced to them. Oxygen cannot travel as easily in a narrowed airway, so we administer albuterol. Albuterol is a drug that causes the muscles in the lungs and airway to relax so that oxygen may flow more freely. We administer this with a nebulizer, which vaporizes the albuterol for easier inhalation. A nebulizer kit can also be found in your EMT bag. There are instructions in the kit on how to assemble it. Albuterol can be found in the blue BLS medications bag of your EMT bag. It comes in single unit doses. You will insert this unit dose into the nebulizer bottle, which is perpendicular to the mouthpiece. On this picture, it's labeled as the nebulizer cup. Once the mouthpiece has been set up, attach the tubing to the oxygen bottle and set the flow rate to 6 to 8 liters per minute. You may give a maximum of 3 doses. If you think more doses are needed, call medical control. Behavioral health emergencies can cause rapid breathing or hyperventilation. Treatment for this includes encouraging the patient to take deep breaths and administering oxygen with the NRB. Transport the patient in the position that they are most comfortable in. Sometimes the NRB face mask can feel uncomfortable for the wearer. If this is the case, then administer oxygen with the nasal cannula. If they don't like how the nasal cannula feels, then you can reattach the NRB mask to the oxygen bottle. Set the oxygen flow rate to 10 to 15 liters per minute, but don't have the patient wear the mask. Instead, have them hold it close enough to their mouth so that they can breathe the fresh oxygen. This is called the blow-by method. And that's all I've got for today's training. So if you have any questions, feel free to reach out.